I provide a very underused part of optics called low vision assessment. Low vision is basically where somebody can't read a newspaper with their normal glasses. Any from that point and onwards, under the Welsh government scheme, is considered to be low vision. That may be through some sort of eye disease or eye injury, cataract, something like that, where we can perhaps look at magnifiers, lights, telescopes to try and fill in the gaps where the glasses don't bring that person to the vision level they require or would like. To try and keep them as independent as possible for as long as possible. It's much more than a job. It's not uncommon to have people crying on you because you've suddenly given them a tool to allow them to do what they've loved doing all their years. We start off really just by discussing their problems. You know, what can you do with your glasses? What would you like to do? What have you had to stop doing because your vision's not what it used to be? And then start addressing those one by one. And as a practitioner, I sort of consider, do those things all fall into the same type of working distance? So taking tablets, for example, or reading a newspaper, they would perhaps be at the same distance. One is, of course, potentially life critical, one isn't. And trying to find the right sort of aid that will give them the best view and make sure that they don't suffer.
I was doing A-levels, health and social care, and then I did voluntary work with adults with learning disability. So I came here as a banker, and then luckily I got permanent then.
Gemma was originally a care companion, and within the time that I've been here I could see that she had much more potential and much more to offer residents at Woffington House. She did some decoration work that encompasses elements of the Butterfly project, so we ensured that those hours continued, and within her own potential I could see there was an element where she could grow further. So she was encouraged to apply for the position of senior care companion, and since she's taken on that role she's also developed further, and I can see her confidence growing.
All our residents are 65 plus, they're all dementia care. I think you need to know the person because obviously there's different stages of dementia.
She's engaging, she's polite, and to me she's got a heart of gold, and we need more people like Gemma working in our sector.
You become a family. Like, I feel like when I work, these residents here, I would want them to be treated as my nana bam. So like I would want to put all the love and all the care into them.
I came to the UK in 1991 to do specialty training in haematology. During that training I became fascinated with transfusion and transplantation medicine and was able to subspecialise in transplantation. And that led to me moving to Wales in 1999 to take up my current position as director of the BMT programme. One of my wishes is to be able to say to patients when they come to that first clinic, really nervous and afraid, that there's 100% chance that we can make you better. And we're not there. And until we're there, I think we remain hungry, greedy almost, to improve things. Things have improved significantly in the decades since I graduated from medical school, but patients still die. And for that reason, you have to keep innovating, keep trying, keep engaging in research. And sometimes you make a big step and there's a huge incremental change, but more commonly, it's actually small sequential steps that make a difference over time. And we just have to keep pushing to improve the outlook of patients who, quite frankly, without a transplant, have a very shortened life expectancy.